This talks on motor neuron disease. And this is exactly what it says. It's a disease of the motor neurons as opposed to the sensory neurons. The motor neurons are the neurons which are carrying information from the central nervous system out to the peripheral nervous system. They're sometimes described as efferent neurons. So an afferent neuron would be a sensory neuron taking information into the central nervous system. An efferent neuron is a motor neuron taking information out from the central nervous system. Now, motor neuron disease is a progressive disorder and the cause is essentially unknown. It's one of these diseases that are described as being idiopathic. We don't really know what causes it. And the cases are typically sporadic. That means one can occur here, one can occur there, one can occur a couple of 100 miles away. There's no pattern to it. They're just sporadic cases. We know this disease crops up, but there doesn't seem to be any rhyme or reason very often to where it's cropping up. And there's about 5 to 10% of cases do have a familiar basis. So 5 to 10% of cases do have some genetic cause. And people have come up with all sorts of other theories for what might be causing motor neuron disease. Some people have postulated viral infections, others trauma, others electric shocks, others exposure to toxins, or indeed combinations of those. We really don't know, but we do know that it occurs worldwide. This disease occurs in any country you care to look at. Now, thankfully, this is not a common condition. The prevalence is about 5 per 100,000. So that means in a city of 100,000 people, at any one time, you'd expect about 5 cases to be about. And the onset of the disease is rare below the age of 30. Fortunately, this is not a young person's disease, but it becomes increasingly common over the age of 50. And typical people presenting with motor neuron disease will be in their 50s or 60s. So, what's happening? What is the pathology here? Well, cells in all motor areas of the sensory nervous system and peripheral nervous system just start dying. There's a process called cellular apoptosis which seems to be taking place. And apoptosis means that the cell basically commits suicide. The lysosomes inside the cell give up their digestive enzymes which digests and kills the cell. But for whatever reason, all the motor neurons just start dying, centrally and peripherally. Now, motor neurons are normally divided into upper and lower motor neurons. The upper motor neurons originate in the prefrontal gyrus in the frontal lobe, anterior to the central sulcus. And from here the upper motor neurons, some go to the brainstem where they synapse, others go straight down the spinal cord. So the upper motor neurons basically are the ones in the brain and taking impulses down the spinal cord. Now the lower motor neurons have their cell bodies in the anterior horns of the spinal cord, in the grey matter of the spinal cord, and they go out to the periphery where they will synapse with muscles. So the lower motor neurons are mostly in the peripheral nervous system, but the cell bodies will be in the spinal cord, which of course is part of the central nervous system. So what sort of clinical features will we get with motor neuron disease? Well, there tends to be brisk reflexes. The reflexes are faster than normal, and there can be fasciculation. Now, fasciculation means muscle tremor. Have you ever kind of been sitting there and your eyelid just starts flickering, like flickering on and off very quickly? That's fasciculation. So you get that fasciculation in a lot of muscles in the body. So brisk reflexes in a fasciculating, wasted limb. The limbs waste because there is muscle atrophy, loss of muscle mass. And this is normal when a muscle is not innervated, when it's not receiving its nerve supply, it loses its muscle tone, it can't actively contract anymore, and it wastes away and becomes smaller because it's not being used. In the same way, if you use your muscles a lot, if you go down to the gym and start working out, then your muscles will get bigger. But lack of muscle use is going to lead to muscle atrophy. So the limbs become weak, there's muscle atrophy, weakness, and there can be stiffness as well. Sometimes the muscles feel a bit stiff. And very often the condition begins in the hands and feet and works upwards. So there can be loss of muscles in the hand first, working up to the arms, loss of muscles in the feet, working up to the legs. So cramps can occur because some muscles are innervated and some aren't, because it's a progressive ongoing disease. So there can be muscle cramps, but the disease itself is not painful. The sensory neurons are not affected in motor neuron disease. It's very strange. All the motor neurons start dying, but none of the sensory ones. There's also weakness in the tongue and the face and the palate, the swallowing muscles. And this is caused by a progressive bulbar palsy. Now, what do we mean by bulbar palsy? Well, palsy is an old-fashioned name that means paralysis. And the bulbar motor nuclei are motor nuclei where there are cell bodies of motor neurons in the brainstem. So there are bulbar nuclei in the brainstem, and these generate new nerve impulses for the cranial nerves. And the cranial nerves are largely those that supply the head. So swallowing is a cranial nerve process. Facial muscles are innervated by cranial nerves. The tongue is innervated by cranial nerves. So there's a progressive bulbar palsy, meaning there's weakness in the face, tongue, and crucially in the swallowing muscles. So someone with a bulbar palsy, the muscles that facilitate swallowing, the tongue and the pharynx and the epiglottis, all the muscles in that area become progressively more and more paralysed and don't work because the cranial nerves are affected. So this is going to give rise to dysphagia. Now, dysphagia means difficulty swallowing. Dysphagia. And it also gives rise to dysarthria. Now, dysarthria is difficulty forming the words. It is a disorder of speech. And this is in contrast to dysphasia, which is where the patient can't think of the words. It's a disorder of language. So dysphasia occurs in strokes where the patient just can't think of the word. In motor neuron disease, the patient knows exactly what word they want to say, but because of the dysarthria, they can have difficulty forming that word. And because of the bulbar palsy, there can be nasal regurgitation. When the patient tries to swallow, the food can come out their nose. And of course there can be choking, because food can go down into the trachea as opposed to going down into the esophagus. And in fact, as time develops, they can't even control the swallowing of their own saliva, and saliva can start dribbling down into the trachea, causing respiratory infections. They can't even swallow their own saliva properly. But there's no sensory features and there's no cognitive features. This is not a dementia. The patient's mind is well preserved, and that means they know exactly what's going on all the time. And unlike multiple sclerosis, there are no remissions. The disease does not get better. Every day it just gets a little bit worse. It's an utterly relentless process of disease progression. And in fact, unfortunately, the disease can progress relatively quickly. Quite a few of these patients can die within a year of diagnosis, and certainly within 2, 3, 4 years of diagnosis. The majority of these patients, unfortunately, will die from complications of the motor neuron disease. Now, there is an exception. You probably heard of the physicist Stephen Hawking. Or was it Stephen Hawking? I'm not sure, one or the other. Anyway, he's a famous physicist. I think he works for Oxford or Cambridge, one or the other. And he's had motor neuron disease for about 40 years now, which is absolutely mind-blowing. He's completely paralysed with it. He can't really speak anymore. But he's still alive and still goes to work, which is fantastic. And I can only assume that the bulbar muscles, the bulbar nuclei in the brainstem are still functioning in his case, and is still able to swallow. Otherwise you would get pneumonia and die. So presumably in his case he's an exception, and his bulbar function has been preserved, which of course is great, but unfortunately not common in motor neuron disease. Interestingly enough, in motor neuron disease, the eye muscles are usually well preserved, so the patient can still look where they want to. The sphincter tone is usually preserved, so they can usually control urine and bowel activity. And sexual activity is usually preserved as well, which can be good. So obviously there are many complications of immobility: respiratory complications, urinary tract complications, pressure sores, continence because of immobility. They physically can't get to the loo on time. There can be loss of bone mass, skin problems, all the problems associated with immobility. But as well as that, a great big risk is respiratory infection. These patients aspirate material and saliva, food, drinks and saliva, rather than swallowing them efficiently, and that can give rise to aspiration pneumonia, which of course is a life-threatening infection, and many patients do succumb to pneumonia. And also there can be weakness of the respiratory muscles as well, leading to respiratory failure. So most deaths actually occur because of respiratory infection and respiratory failure. So how are we going to manage these patients? Well, unfortunately there is no cure for this condition. That means we're into a terminal care situation, a palliative situation, essentially as soon as the diagnosis is made, because there is no cure. So think of all your nursing activities of daily living. Maintain a safe environment, communicate with the patient, allow them to communicate, look after their breathing as far as you can, look after their eating and drinking, elimination, help with their washing and dressing, help them to control their body temperature, mobilisation for as long as possible, help them to work and play, help them to express sexuality, help them with sleeping, and ultimately, of course, help them with death and dying. All of the activities of daily living. These patients are a great nursing challenge. Now, medically, there's a drug called Riluzole, which is an anti-glutamate. Now, glutamate is a chemical transmitter, and if you reduce the amount of that, it seems to help a bit, and that can give the patients, on average, about another couple of months of life. So it's probably well worth doing. We want to prevent the complications of immobility, prevent cramps, drugs like baclofen, but simple things like active and passive movement of muscles can all be very helpful. And we want to prevent aspiration as far as we can. So in the early stages, spend a lot of time feeding these patients slowly with things they're not going to choke on. But later, most of these patients have PEGs. That is a percutaneous, that means through the skin, gastrostomy. Gastro means to do with stomach. Ostomy means opening into. So this is a feeding tube that goes directly through the skin into the stomach. PEG stands for percutaneous endoscopic gastrostomy because it's passed with the aid of an endoscope. So the feeding goes directly into the stomach, so the patients don't have to swallow it. That means they're less likely to aspirate any food. In fact, if a PEG is in place, the only way they're going to aspirate food is if it's regurgitated. Now, as the respiratory muscles become weaker, the intercostal muscles and the diaphragm become weaker, a lot of patients feel better with non-invasive ventilatory support, such as CPAP, continuous positive airway pressure. And some patients can go on to invasive ventilatory support with a tracheostomy. Some patients might choose not to take that step. But as always, get all the help we can from our friends, the occupational therapists, the physiotherapists, and speech therapists can be particularly useful in patients with the dysphagia and dysarthria. And patients with motor neuron disease are usually very well informed about their disease and are aware of the prognosis, that the prognosis is bad. So bring your full powers of nursing support to these patients. Include spiritual support, psychological support. Because death from pulmonary infection and inhalation usually occurs in about 1 to 3 years after diagnosis. So feel free as well to use opiates and sedation for any distress that might present in the terminal care situation. Well, just before we finish this podcast, it's worth noting that the Americans call motor neuron disease ALS, amyotrophic lateral sclerosis, but that's their problem. But that's